Welcome back, everybody. It's Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got the usual crew here. We got Caleb Ferrone. We got Dr. John Hill, and a very special guest today. We have Dr. Ariel Olicker from University Hospital's Neonatology. You're an attending physician and assistant professor of pediatrics there. Welcome.
Thank you.
We wanted to do. There's been several field births and resuscitations that have gone on in various, both pre-hospital and certainly in the critical care. I know about that last situation with the preemie, but we wanted to get you on and just kind of talk about all of this neonatal resuscitation stuff, and I think it's kind of a. We really hope it never happens, but you do EMS long enough, you're going to deliver a baby, and then that on top of itself is stressful enough, but then to subsequently turn around and then need to resuscitate the unwell baby, I mean, it's just I guess borderline terrifying for most of us, right? And I'm so glad that you were anxious and willing to come on here and talk with us about these things. So again, thank you so much for coming on.
Thank you. I'm happy to be here.
Yeah, no, this is great. I mean, I guess where do we start? How do we identify that we're in trouble? John will have you talk a little bit about the actual field birth in a little bit here, but how do we know when we're in trouble and we need to start actually resuscitating this newborn infant in the back of my ambulance in somebody's living room, where whatever situation we find ourselves in? I mean, what are some indicators that we're in trouble?
Yeah, so it's really easy to identify a well infant, right?
Yeah.
So a well infant's going to come out. They're going to cry. Usually they're going to cry vigorously. They'll have good tone. They'll be kind of curled up. They'll want to stay curled up. All babies start off blue, and this is a big misconception. People think babies should come out pink, and they don't. None of them do. So all babies will start off blue. But within the first couple minutes, a well baby will start to pink up. So if you've got a baby who is crying, and if you're not there for the delivery, you're probably going to miss that blue stage, or hopefully you'll miss that blue stage. But if you've got a baby who is pink and crying and kind of curled up and tight, that's generally a well baby.
That's good day.
Yeah.
Okay.
If you have a baby, babies don't necessarily have to cry. They usually cry on the way out when they're well, but they don't need to continuously cry. So if you get there and a baby's already been delivered and they're breathing nicely but they're not crying, that's okay.
Okay.
A baby who's breathing nicely and pink and has good tone is still going to be a well baby. The ones you need to worry about are going to be those ones who a few minutes in are still not pink, so they're blue, or they're kind of on their way from blue to pink, so kind of your purple baby, if you will. Babies who are not kind of tight and flexed, so the ones that are more extended or floppy.
Floppy.
Babies who obviously aren't breathing, those are going to be the ones you're concerned about.
Super, yeah. Well, good. And then I think one of the other, and we touched on this a little bit when Dr. Yaski was on with, needing the proper equipment is, we can't be substituting in our adult stuff for this, as we need very specific.
Most of it anyways, yeah.
We need very specific, properly sized equipment for this, specifically for this population. I mean, there's a little more variance in our peds and certainly in our adults. I mean, small adult versus regular adult. Yeah, okay, we can make it work in most cases, but this is a case where, properly sized equipment is kind of a must, right?
You can go both ways on this. So some properly sized equipment is always going to be a must. Sure. So when you're doing things like artificial airways, you're going to want to have the appropriate sized artificial airway. Too big isn't going to go in. Too small isn't going to be able to be used to ventilate.
Right.
Certainly having angiocath small enough to go into the newborn vein, things like that. Other things, though, we can't expect you to carry everything, right?
Sure.
And so sometimes there is going to be some creativity. So talking about things like using the umbilical cord for venous access. It'd be great if you had umbilical lines, but I can't expect EMS to carry umbilical lines. Right. So we think about what can we do with what we have.
Right.
So we've talked about things like using angiocaths or using feeding tubes
that's sitting here. We're gonna get back back to that. But yeah, absolutely.
So certainly you need to have some of the properly sized things that are irreplaceable: masks, tubes, vascular access, things like that. But other things, we can be a little creative with what we have, and we can meet you where you are.
And I think to add to your point, Doc, is that we're also using different scales. I mean, we have the Appar scale, we have maybe the Roswell tape, so we're not using those on adults per se. So there are other things that are tailored to this as well. And I think that you made a good point there, that they're going to come out probably not screaming at first, not pink yet. It takes a few minutes. So I think doing Appar scales, it's important to remember that might not be perfect for the first one, but you need to trend that and do a second one and compare and see where the baby's progressing or digressing.
Yep. So we generally do them at 1, 5, and sometimes 10 minutes. Oftentimes a well baby will have, so if we're going to be technical, no baby will ever have an Appar score of 10. I know people love to give people Appar scores of 10. And the reason for that is it takes much longer for the hands and the feet to turn pink. And so for color, you always lose 1 for acrocyanosis. So a blue baby is a 0, a baby with acrocyanosis is a 1, a completely pink baby is a 2. And so that's why you never see us in the hospital ever give a 10.
Grade of a 10, right?
But aside from that, you will oftentimes see in a well baby at 1 minute an Appar score of 9. But if you don't, that's when you start to trend them. And even sometimes Appar scores can even go down. Sometimes a baby will cry initially and then stop breathing. And those are babies who need some help.
What's your trigger for additional trending? So we're classically taught 1 in 5 minutes.
1 in 5.
And that's it. It's like,
and generally,
you don't need any more.
And it's okay not to document 10 and 10, like I'm saying. That's good. Don't do that, because it's probably not normal to be 10 and 10.
If that second is trending down, or if you think the overall clinical course is poor, that's the time to continue it.
In general, if you're still resuscitating, you're still giving scores. And so the rule, I think, is if you score until your score is greater than 7, I believe.
Oh, okay.
But if you're still resuscitating, you're still going to be giving scores.
I don't know that has ever been said to me.
I've never heard that.
No, I don't know that's ever been said to me. So that's great. That's great information.
No, I like that.
Yeah, score until so.
I would say if something changes too, right? So you do your initial, your birth, everything's fine. Baby starts to deteriorate, like we talk about vital signs. You're going vital signs for kids, or it's going to be Appar score, right? On top of pulse, right? We can talk about pulse ox here in a little bit too. But making sure the patient has a good, strong, fast pulse, not a slow, Brady pulse for kids. Making sure their respirations are fast and moving adequate air. And then if there's a change, I don't think there's any reason not to rescore them as Appar as part of their vital signs.
And you can do it later. Yeah. So in general, you're recording vital signs, right? We don't do Appar scores in the moment. We do them after we're done with things. So we go back and we look at our resuscitation sheet, and I'll go back and look. At this moment, I was giving breaths, but my heart rate was good.
Sure.
At this moment, I was giving breaths, and my heart rate was 80. Yeah. And so we'll go back and do them afterwards.
And trending that seems intuitive, but I'm stressing that and I'm bringing that up because I know that that's not taught to be that kind of a dynamic thought process. It's really like you must have these 2 points of information, and it's essentially it, right? It's like for the newborn, especially classical textbook teachings and stuff like that. So it's good to hear that. Use it more dynamically and use it more intuitively based on your case presentation.
Yeah, and to take some of the pressure off of it, we take Appar scores with kind of a grain of salt. There's 5 components to it. Each one has up to 2 points that can be assigned, which is where you get your 10. There's heart rate, which is going to be more objective. There's respirations, which has a little bit of subjectivity to it, but it's going to be more objective. There's color, and this is where the subjective parts start to come in. There's color, which is going to have some subjectivity to it. There's tone, which is going to have some subjectivity to it. And there's reflex irritability, which is going to have some subjectivity to it. And so we take a look at Appar scores, but in general, we take them with a little bit of a grain of salt. If you tell me that a baby's Appar is 7 or you tell me a baby's Appar is 8, it doesn't mean all that much to me. If you tell me a baby's Appar is 9 and a different baby's Appar is 2, those are 2 different babies.
Yeah, those are wildly different cases, sure.
I like what you said about the color too. I mean, because that's important. We talked a lot about field resuscitation not that long ago. I don't think I was on that episode, but I remember hearing the modeling versus, lividity, and it's important. Not everybody sees it the same way, and I think that we need to see this color the same way.
By the same token, she has the opportunity to see well and unwell babies
Right.
all the time, right? And
We don't.
she's going to be far better tuned to those subtle differences than we would, right? But yeah, it's
I
great
think-
to
I
bring
think
up that subjectivity
Bigger
point.
for us, though, as far as the paramedics go, the class and all that, is that if you have a baby who's central cyanosis at first, not getting better, that's worse than somebody who's slowly pinking up and getting better. I mean, that's where we really need to step in and say, oh, we got to do something different.
All right, so
Slowly pinking up and getting better is exactly what you're looking
Yeah.
for. You don't necessarily even want to try for a baby to go straight from blue to pink.
0 to
But,
100 right now.
Yeah,
It's just not going to
that's-
happen.
That's not your goal. Your goal is over the course of the first 10 minutes to get from deoxygenated to oxygenated. And so you actually have a good amount of time to get to a SAT greater than 90. And if you think about it, when you're resuscitating, you're focused right here, right?
Right.
You're not focused on the rest of the baby. It's silly, but the sicker a baby is, the less likely I am to know the sex after I'm done resuscitating.
okay.
And so you're focused right here, and you've generally got a mask right here. So you have a really good look at the area that you want to see get pink, and you can watch as your mouth starts to turn pink or not. And that's the best indicator of how well you're doing
And I think
in
despite,
terms of color.
race and background, I mean, even on a darker child, that lips should still be a pretty good indicator of color.
Lips, and especially, I generally try to look at the tongue.
Tongue.
Tongue, so-
You'd be surprised, even in more dark-skinned families, all babies actually come out pretty light.
pretty light. As part of that airway management, we're going to kind of frame this up in the adults, right? In the adult side of things, because clearly that's what EMS does the most, right? We may be very apt to go quickly to an advanced airway. Do we need to delay that, or can we run it at kind of with the same gusto? Like, we walk in, check a pulse, patient not breathing. We might bag them 4 or 5 times before somebody's putting a supraglottic in them, or somebody's using that as a bridge while they're setting up endotracheal intubation. Do we need to drag our feet a little bit more on that, or
You can have
is
some
that,
patience,
or
and
is this
you can have some patience, and if there's any skill, as we were talking before we started, the newborn airway is going to be different than the adult airway, and if nothing else, it's smaller and harder to see. It's also pretty delicate. It can be lacerated easily. Once you lacerate an airway and you have a lot of blood back there, it's hard to see anything.
right?
Oftentimes, the airways just have a lot of fluid back there from amniotic fluids and stuff. And as you suction things out, if you have a little patience, a lot of times, once you sort of jumpstart a baby or get past what we call primary apnea. So primary apnea is a baby who comes out not breathing.
Okay.
Secondary apnea is a baby who comes out breathing then stops.
And subsequently stops. Okay.
So if you are able to bag and mask a baby past that primary apnea point, and sometimes you can, sometimes you can't, and a lot of this, some of it's going to be breathing, some of it's also going to be heart rate. But a lot of times we can bag and mask a baby past that initial primary apnea or that initial stunned period into a baby who can be transitioned to no support at all or considerably less support. And the less you have to instrument an airway, the better. The less likely we are to have swelling and even our littler babies, when airways get traumatized, it can be traumatized for the long haul and cause issues that make us, thinking way down the line.
Yeah.
You can get things like subglottic stenosis, which causes us issues extubating way later.
Sure.
Do you see that more with intubations or like supraglottics or let's say oral airways?
So everything subglottic stenosis is going to be with intubations.
Okay.
As far as the supraglottics, so I would love for everyone to have the skill of good bag masking. The next thing that we'd love to have everyone have the skill.
So would we.
I can BVM a lot.
And we can look at it and talk about it. I'd love for everyone, and even when we have our own residents, our goal for them is not necessarily to make them good intubators, but we want them to be good bag maskers. You can bag mask a baby for a long time.
Yeah.
But our next goal, especially for EMS, who doesn't have a lot of opportunity to resuscitate newborns or to intubate newborns, our next goal is to get them to be able to do something that is going to be easy, that they can do quickly, and that they'll be confident with. And so supraglottics is going to be your easiest tool there. And so while it would be great to be able to have these babies intubated in the field, I'm happy if you can do supraglottics.
Supraglottic, yeah.
I love the point you made, because you can bag somebody much easier if you're doing proper technique. And why fix it if it's not broken? If I'm bagging, if I'm getting good circulation, I'm not going to, go from that path. I've never intubated a baby, in my career. It's been over 20 years. And I've never done that. So I would definitely go with a subglottic airway.
Same here.
But I think more importantly, as we go back to the equipment, using the BVM you have there and not this one is huge, because I don't want to overpower those lungs, and this is about all we have anymore. And to see these smaller ones, it makes so much more sense.
Yeah, I've got little ones. You can use big ones. You just have to be careful with
very careful.
the amount of air you're using.
Proper technique's huge. And again, I think if you're able to get oxygenation, ventilation with that, why go from that?
And if you're confident putting in a supraglottic airway, if you're confident placing an LMA or an iGel, and you can get good chest rise and your baby's pinking up, that's all you need.
But I think, like to your point, Scott, I mean, if we have an adult patient who collapses on us and we're BVMing, we're going a couple minutes and going right to an advanced airway. It's like
our threshold for that is generally very low, right? And that was why I framed that up.
I would give a baby a moment to kind of turn around. Babies sometimes just need a moment. You can give them a good few breaths, and sometimes they will scream at you and
tell you to stop.
Yeah.
It's the best thing that they can do for us.
Right, yeah.
If you have a baby who's screaming and fighting you, trying to put in the airway in the field, that's a baby who doesn't need an airway in the field.
Right, doesn't need, yeah.
I think it'd be extremely rare that this child would have a cardiac event as opposed to respiratory event, though, right? I mean, we need to focus on the airway, not defibrillating, because it's not going to probably need it.
That is a huge, huge point. It is where NRP and newborn care differs from pediatric care and adult care. In pediatric care and adult care, when they go down, they're going down oxygenated, right? So those are people who were previously breathing and previously oxygenated who are going down with oxygenated blood. So when you're talking about lay BLS, and we did things like get rid of rescue breaths and lay BLS, that works because you're going down with oxygenated blood and you're circulating oxygenated blood. When a baby comes out, a baby is deoxygenated, and you can do compressions forever. And if you circulate deoxygenated blood, you're not in any better a spot than you were if you're not circulating at all. And so airway and breathing are the two most important parts of NRP, and you usually don't have to go past that. If you can open up the airway, not necessarily with an advanced airway, you just need to generally open the airway. So clear the airway of secretions, get the airway open, get a baby into a good sniffing position, and breathe for the baby. That's usually enough to bring your heart rate back up on its own, and you don't usually have to go from there. There's actually not an initial NRP. The defibrillator never comes into it at all.
They're like, what's that thing?
Yeah, it
It's a
makes
big
sense.
paperweight.
There are instances when we do cardiovert, but not generally in the delivery room. I've, in my career, never defibrillated in the delivery room.
Let's keep it that way.
Yeah, right.
Yeah. Once you do get past airway and breathing, if your heart rate still isn't coming up for you, the next part's actually to put in. By NRP, you don't necessarily need to, but the next step that makes the most sense is to put in the advanced airway at that point before you start compressions.
Sure.
And if you don't put in an advanced airway before you start compressions, there are several issues. You are oftentimes closing your airway by giving compressions, and so if you are trying to give compressions and breathe through a bag mask at the same time, you're often doing it through a closed airway. Yeah. You can also, with your compressions, push out the air you're trying to push in, and so it's important to synchronize them.
Yeah.
And so once you're to the point where airway and breathing isn't doing it for you and you have to move on in the steps, that's when you certainly want to put in an advanced airway. But if airway and breathing is doing it for you and the baby is just not developing their own respiratory drive, you're not going to want to transport giving bag mask ventilation. That's also when you're going to want to intubate.
I think that'll separate paramount, though, between good providers and not, is that with adults, we're jumping towards AEDs. With peds, we need to focus in on airway, period. and just work the problem. And
Focus in on airway, focus in on breathing. Most babies are never going to need compressions, and the vast majority of babies will never need an AED.
And then what is your threshold for the airway and breathing not working before you're transitioning? Because, of course, protocol and, our classic teaching, heart rate less than 60, start compressions. I'll tell you, most providers, again, having not done many of them, and I think they'd puff, puff, nope, kid's not picking up, heart rate's not coming up, and they'd immediately go to the chest.
Or maybe they just suctioned and vagal stimulated and...
Correct. So, I mean, like, what is your your threshold for that? A couple minutes minimum kind of thing?
So if
are you looking at other indicators?
So if you're talking about compressions, NRP is pretty specific on this. If you're talking about compressions, the first thing you want to get is effective ventilation. So it is, you move on to compressions when your heart rate is still less than 60 after 60 seconds of effective ventilation.
Okay.
It's not just 60 seconds though. It's 60 seconds of effective ventilation.
Got it.
So that means I have chest rise and fall, or does that mean I have raising SpO2 levels? What is an
You have-
effective ventilation?
You have chest rise and fall. So remember, if you don't have circulation, you're not going to get rising SpO2
So I need
levels.
mechanical ventilation.
Well,
I need to
bag
see
mask.
it. I need to see
Yes.
it.
Yeah. What's your heart rate threshold to give us to start BVMing a patient? Like if they drop below 100, if they drop below 80, at what point are you?
So we start bag masking if you are dropping below 100, but also just if you're not breathing.
Fair.
That's one people forget, right?
Sure.
They forget.
Well, if I'm breathing and baby's not breathing, baby should be breathing
Yes.
at least as much as I am.
Jeez, and if this was me, I'd be breathing pretty quick.
Because we talk about that too when we're bagging, right? If you're breathing and you haven't breathed for your patient, you should do it. Same here. If you're breathing and baby's not breathing, baby should be breathing. You should intervene.
Yeah. Baby should be breathing faster than you are, though, hopefully.
Yes. How fast should we be bagging these patients?
You want to do it. Yeah, you want to do it at a rate of 40 to 60 breaths per minute.
Which is very different than we do in the adult world.
12
It's
to
very
20.
different. And so when we're teaching things like NRP, when you don't have an advanced airway, so when you're just doing it with a bag mask, people actually tend to breathe too fast. And it may honestly be different for people whose world mostly revolves around adults, actually, because you're used to breathing, 12 to 20 times a minute?
Yeah,
12 to 16 is ideal, but we end up probably more around 20 is probably what average people are because they're just
Excited.
They're excited, they're
Yeah.
worried.
So it may honestly be that this isn't going to be quite as big an issue for EMS as it is for pediatricians, say. But people do tend to, even in a baby, bag too fast. And so for us, in order to slow it down, sometimes, and when I'm leading codes, sometimes I feel like this is really my role, but I'll stand there and I'll say, breathe 2, 3, breathe 2, 3, breathe 2, 3, when you're doing it with a bag mask. When you're intubated, it's a little bit different, or not intubated, I'm sorry. It's the same when you're intubated, but still bagging.
Yeah.
Once you start doing compressions, it changes a little bit, and it's 1 and 2 and 3, hold, breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
Okay.
And that hold is the important part, because that would be where we would fail in the transition from the adult mindset, because we would just continue with the chest compressions. We wouldn't put that pause in there. I mean, that's beat into our heads on the adult side.
Correct. We want to limit time off chest.
Time off chest, right, is hands-on time.
The baby's chest is so compliant, that if you try and give a breath while you were giving a compression, you'll just push your breath back out.
Yeah. I mean, that's a simple little thing that I know would go overlooked. I mean, because we would fall back on what our experience is, right? And that's usually the adult population.
And hopefully we never see a Lucas on this.
Oh my goodness.
The Lucas will tell you no.
But it comes back to knowing your equipment and knowing what is right for babies and not.
We talked a little bit off camera about, and actually we were looking with a laryngoscope, with a vastly oversized laryngoscope blade at
What size was that?
It was probably a 2. But
I mean, I would use a 1 on her. It's not vastly oversized.
It looked gigantic, but yeah, because I think it was the top one in that stack, so it was 2, 3, 4 over there. But and you were saying that our anatomical, if we are at a position where we need to take their airway, and endotracheal intubation is the choice, whether we don't have a supraglottic, and you've got here an iGel, and you've also have an LMA. But if you don't have either of those, or the decision is to intubate, you were kind of describing some of our usual landmarks that we train on aren't necessarily what we'll see when we go in.
The one that you are looking for the most is going to be what you're not going to see.
Not going to see.
So in general, the technique is going to be similar, I think.
Softer.
Miller blade versus a Mac.
Right.
Yes, we are using Miller, so we're always using straight blades. So you're going to want to go in, and my general technique is I just go in deep. I assume that my blade is in the esophagus. You want to pull up toward the corner of the wall, so you don't want to rock toward your face. You want to pull up toward the corner. And then I slowly back out, and you'll see the epiglottis flop down. Just like it does in an adult, I assume. We were joking earlier. I've never intubated anybody with teeth.
A lot of our patients don't have teeth either.
Yeah. For very different reasons. Because we took them out.
I was going to say, hopefully they had teeth before.
No, they did.
They did. We just removed them to do the intubation.
So your epiglottis will flop down, and you'll see your airway, and it'll look more like a soft triangle as opposed to that nice hard triangle you're used to seeing. But in older kids and adults, you are taught or you've seen that they have these nice pearly white cords.
Yeah.
And in infants, they don't. In infants, they're going to be pink, just like the rest of the airway. If you're intubating a baby who's breathing, even ineffectively, you will be able to see the cords flopping open and shut, just like you can in an adult. You're probably paralyzing adults before you intubate them. But
not always.
Not necessarily. Not
ED,
necessarily.
yes.
Yes.
Pre-hospital, they do have.
There's pockets that do RSI. Yeah.
But it's definitely not standard of care. It's not widely accepted. But
got it. And we do it in the NICU for non-emergent intubation too.
Yeah.
We don't do it in the delivery room. But if a baby is breathing but not effectively and you have to intubate, you will see the cords opening and shut just like you would in somebody older. But they're not going to be that nice pearly white. They're going to be pink.
Yeah.
I thought that was a phenomenal point. I
Yeah,
never had
you're right.
been taught that.
And we both said
And I think every mannequin-
we're gonna go back and check even. So I think our old mannequins absolutely have white cords.
Oh yeah.
But that new one I want to check.
I'm
I can't remember.
90% sure they were painted.
Yeah, she doesn't.
No. So. Yeah. Simple little thing to know, right?
Yeah.
Yeah.
It's a big deal.
Do you carry enteric tubes that you can put down in the field? Small ones?
2.5 was probably the smallest that I would.
Oh, you could even go bigger than that.
Yeah, but the smallest that I think we would have, most would have, is a 2.5.
You could use a 5 and 8. Sometimes even a 10 in a bigger baby. But if you put down an OG tube.
I'm sorry. Your question was OG?
Yeah.
OG, no.
Okay.
Don't. Just don't.
It's one
Just
of my pet
stop,
peeves.
stop. Just stop it.
It should be.
I'm sorry. Your
OG
question,
tubes are your pet peeve?
Well, we should be doing them, and they're not in our protocol.
Well, what I was going to say.
No, I'm sorry. No, I misunderstood. I thought you were talking about ET tubes. No,
Yeah, you
no
can't-
OG
You
NG
can't shove a
tubes.
2.5 tube down them. Well, you can, but.
I wouldn't recommend it.
Let's not say we did, right? I'm sorry. Your thought, though, was. And again, we've got a national audience, so,
Some people are doing
maybe
that,
somebody
yeah.
has it, but I
Gotcha.
misunderstood your question.
Or I know, for example, our critical care transport team does have
Absolutely.
enteric tubes. And so if you put an enteric tube down, you can leave that in. And so when you put in your blade and you go deep
You
and
can
you
spot
pull up,
landmarks.
you can see your enteric tube. And as you start to pull back and your epiglottis flops down, your enteric tube's going to go out of your field of view. And then you're looking at the airway.
What's your position? I know that nationally the position has changed, but cuffed versus uncuffed tubes, and have you seen any differences in your practice using them? Are you still inflating if you are using them, or do you just?
We are almost exclusively not using them.
Not you.
When babies go to the OR, they sometimes come back with cuff tubes. There is the very occasional baby who is between tube sizes who will put in a cuffed tube with the cuff down, just to give us a little bit more occlusion, just because our leak is so big that we need something there. But in general, at least our practice is that we use almost exclusively uncuffed tubes. And the reason is that pressure that you're putting on the trachea below the glottis is going to be, at that point, it's going to be a pressure point. And we have tubes in sometimes for hours or days, but sometimes for weeks or months at a time.
Yeah.
And that's a point that will eventually, if pressure is put on it for a long time, and maybe even in the days to weeks area of long time, be a point that can scar down and cause a point of subglottic stenosis. And at that point, you have an abnormal airway, which is going to be a problem later. And
At
can
some
even,
point, sure.
I
Yeah.
think it's important, just talking differences in equipment, that if we do inflate, we have to be careful how much pressure we're putting in there. Don't blindly throw 10 cc's in there. They won't accept it. And if you do, you're causing trauma.
I don't know that our cuff tubes can even
Can't
hold
even-
10 cc's.
But everybody's going
We're
to take
so
the
used to
syringe and
adults that have they can accommodate a lot, but if you're throwing like a 7 on an adult patient, yeah, you could easily get 10 cc's in that.
Right.
We have a baby who just got a trach, who has pretty significant tracheomalacia, so a kind of bigger floppy airway, and had no leak at all with 2.5 cc's.
see, that's just enough to start inflating the tube for us.
Well, this is a total aside. When you said leak on a kid, I'm thinking, yeah, I get leaks that are like 10s, 20s, 50s. Get above 50, that's probably a lot of leak. I'm thinking a leak for your kid, 50 is probably the whole volume.
Total
you're
air,
ventilating-
yeah, that's-
ventilating your patient.
So I think.
So your leaks are probably, you're talking
Are
small
you talking about in mLs or percent?
mLs.
So when you think about babies and their tidal volumes, when I'm thinking about minimal vent settings, or a baby who just needs a ventilator because they're not breathing, so has lungs that can ventilate and oxygenate, my usual starting point for ventilation is going to be 5 mLs per kilo. So if you
Okay.
think of your standard...
That's even below what we do for adults.
Right.
Because we typically start at 6. Our goal is 6 to 8.
6 to 8.
Oh, okay. So if you think of your standard 3 kilo, just for round numbers,
Yeah.
3 kilo baby, your tidal volume is going to be 15 mLs.
Yeah.
Wow.
If you think about your tiniest...
That's my leak on a patient with CPAP on.
if you think about your tiniest 500 gram 24 weeker,
Yeah.
your tidal volume is going to be 2.5 mLs.
That's crazy to me.
That's crazy. That's more than what's in there.
Yeah,
Yeah.
I mean, just to contextualize that, it's 2.5 mLs. That's your tidal. That's nuts.
That's tidal volume for
That's tidal
premium.
volume, right?
And now you see why that mask was, or that bag was too big.
Yeah.
Yeah.
But no, actually, I'm glad you brought that up and talked about that, because I mean, to contextualize that, that's a big deal.
Yeah, but in order to prevent airway trauma, so I think in adults you're generally looking for no leak, right?
Ideally, but I mean, I accept leaks on vents all the time, right? I expect it in a few mLs or tens of mLs is okay. And we see a lot on PAPs. Or
About to say on your non-invasive.
on
yeah.
our non-invasives,
Yeah, of course,
but
of course.
I mean, this is going to blow your mind. I'll see 1,200 mLs of tidal volume on a patient that's really working to breathe on
non-invasive, on bypass.
because they're
sure.
taking that big
Sure,
giant
yeah.
breath.
I don't think I have 1,200 mLs of patient.
So see, and intermittently I'll see leaks even to like 150 depending on how the mask is.
Yep.
But a typical leaks of 10, 20. But again, that could be your whole volume. which
So
is
we're
crazy.
actually-
That's nuts. Yeah.
Yeah.
So, but you're looking to minimize your leak.
Of
And
course.
we're looking to minimize, sure, but we actually want some leak. If we don't have a leak at all, we're actually worried about that.
Sure.
And those are babies that we are worried as we get to that point about extubating. There are babies who have 100% leak on the vent, and before we go to straight upsizing the tube, we'll actually see what we can do with positioning the baby and positioning the vent tubing to see if we can kind of overcome our leak and still ventilate, just because we're trying as hard as we can to avoid airway trauma.
What I took from all of this is bag first,
Mm-hmm.
and then if we have graduated after at least a minute, if not more, that we're going to put an advanced airway in,
Choose
Supraglottic eye gel.
Yep.
because that's what we'll have in the field, or if you have a laryngeal mask or whatever you have, and then transport.
Yeah.
That's
Yeah.
what I heard.
I like
Because
it.
even me, if I receive this in the ED, I now know that I'm going to leave that eye gel there if I'm going down my ABCs, right?
Mm-hmm.
Airways intact, we're ventilating and oxygenating the patient appropriately. I'm going to transport to you to have you guys worry about advancing, putting in an ET tube, and not to disturb the upper airway, but lower than the
the
glottis
yeah.
area, so that way it don't cause trauma.
If you can bring us a baby with a well-seated supraglottic airway who has good chest rise, I'm happy.
Perfect. Deal.
Can do. Can do.
So kind of going back to your point, though, I mean, with an adult, a full arrest, seeing that we've talked about field resuscitation in past episodes, sometimes there's stay and play and sometimes there's not. And you were going to talk a little bit about a normal delivery and that stages of that. I think, women have been giving birth naturally for thousands of years without any medical assistance, and things have been fine.
They have been.
And I tell my guys all the time that I don't believe childbirth is a medical emergency. It's life. There are a small percent that might turn tail on you, but I think maybe if you talk through that, what is a load and go, and what is a kind of just, hey, let's get this airway, let's chill out. What point do we transport?
So let's go back. Let's start with natural childbirth. Let's say you're called to a scene and mom's crowning. You can have that conversation about what number child this is. If they've had multiple kids, this is baby number 4. Baby's coming out a lot quicker than have never had a baby before, never passed a child through the birth canal. Crowning, I would just stay there and work the scene, deliver baby. So they're going to crown anterior shoulder, posterior shoulder, put baby on top of mom on skin to skin. I think their first step of any resuscitation for a newborn is going to take dry towels and vigorously rub that kid. That's the best thing
Tactile stimulation.
Tactile stimulation. You want to dry them off so that way they're no longer wet. You want to get them on skin to skin with mom or dad or whoever is going to be a warm body to keep them warm, because we've had a recent case where we didn't keep a patient warm.
Right.
And then keeping them dry and then just not playing with them, but doing that stimulation so that way they'll take their first breath. They'll cry. They'll start to pink up as they start to really kind of move that air. And a crying baby to me is the best thing I can hear.
But wait, you haven't clamped the cord yet?
So, do you want to talk about delayed clamping? Is that outside your purview?
I just think textbooks always tells you as soon as the baby's, you clamp. It's like, whoa.
Nope, the new thing is delayed.
There's a body of evidence.
Body of evidence. Because we want more blood to go to baby. Let's pick baby up, dry him off, put him on mom, make sure baby's doing okay. Oh, crying, great. We can get our stuff out we should already have it out, but set up our clamps. We're going to put our clamps on, and then we're going to, most importantly, cut in between the 2 clamps.
Yep.
So that way we can occlude the side. And then make sure the next step to that is you're not done. Baby might be doing okay. You want to watch baby, but then next thing is to then make sure that placenta gets fully delivered.
And an old textbook was that every time we saw head, we would suction mouth and nose. There is an importance. They're obligate nasal breathers. What are you suctioning first? But are you leaning away from? Do we have to do that every time, or are you doing that? And what if you see meconium?
I can feel this if you want.
I wouldn't. You can, if baby's coming out and baby's head's out, you can suction if you have time. I wouldn't necessarily take the time if we're delivering.
NRP actually recommends against it now.
Okay. So I would deliver baby, get baby out, rub. Again, as you said,
Skin to skin.
Clear out
skin to
airway
skin,
thereafter.
Yeah. Baby's been doing this for a long time without our help.
And
and
keep
I
in
kind
mind,
of leaded that question because I know that recently they've changed their mindset on the suctioning, and it's really thrown some older paramedics for a
In
loop.
our time, there has been a swing in that.
Yeah.
Absolutely.
so yeah, there's some evidence, and the reason NRP recommends against it is there is some evidence that there's actually more need for resuscitation when you try and suction at the perineums when the head is delivered, but the rest of the baby is not delivered. And so NRP recommends recommends against suctioning in that situation. So deliver your whole baby. Keep in mind that once your baby is delivered but your cord is not clamped, the baby is still attached to the placenta, and the placenta is still at that point an organ of respiration. So while the baby is so placental blood is baby blood, if you think of it that way. Mm-hmm. So while the baby is still connected, while you are doing your delayed cord clamping, the baby is still getting the respiratory properties of the placenta while the placenta is still attached. And there are very few true contraindications to delayed cord clamping. Pretty much the only really true contraindication to delayed cord clamping is going to be an abrupted placenta, because at that point your placenta is not acting as it's not acting as your organ of respiration, and it is bleeding, and so you are losing baby blood at that point.
I love that you brought that up,
No,
because when you think about water births and people freak out that the baby's born in the water and the baby can't breathe, it's like, oh, the baby doesn't need to breathe yet. Just give it a minute. It's like,
Yeah.
You just went from outside water to inside
Inside
water.
water, right?
As long as that placenta is still attached, the baby is still getting
You're in good shape.
what
yeah.
it needs from its placenta.
I
And
love that. Yeah.
and so, as far as meconium goes, the guidelines on this have changed in the last several years. Between the last 2 editions of NRP, they've stayed the same, which I guess is nice. But the recommendation before I started, but not long before I started, was every baby with meconium got intubated for suction.
And deep suctioning.
Yeah.
Mm-hmm.
Which
Through
was
an
the same for us in the day, basically.
Yeah.
Yeah.
Certainly,
So-
certainly what I was trained in.
Yeah, so NRP at that time was every baby with meconium stained fluid gets intubated for deep suction. And that guideline has changed over time. And so around the time I started, every baby who was born vigorous did not get deep suction.
Right.
But babies who were born not vigorous, so your not breathing baby or floppy baby, your baby with bad tone, those were the babies who used to get still intubated for deep suction. Now, actually, every baby, even with meconium, comes out in the first step of NRP, even with meconium, is going to be dry and stem. So the thought used to be that if you deep suctioned, you were going to prevent that meconium aspiration. And it was actually, I believe NRP came up with this new recommendation by looking at outcomes in resource-poor countries where they didn't have the resources to intubate all these babies. And they had similar rates of meconium aspiration syndrome as we did with our intubating for deep suction. But with babies who have significant meconium aspiration syndrome, it's not that meconium that is present on the baby or in the mouth at the time of delivery. It's meconium that has been aspirated.
It's chronic.
It's not chronic per se. It's kind of subacute. But it's that meconium that's been aspirated before the baby
Long
has been
before,
delivered. And in sick babies, what can happen is those babies will gasp and they'll take in particulate meconium before they come out. And that's the meconium that's reaching down past your large airways into your smaller airways and really causing you issues. So, I mean, certainly bulb suction if you see an airway that is occluded by anything, but
Sure.
including meconium stained fluid. But your next step is going to be dry and stem. And it's always going to be dry and stem.
Is there anything else on a normal delivery? I mean, that was the high-level overview.
That's just high level overview.
Yeah.
And that's how 99.9%
Sure,
of your
sure.
deliveries are going to go. They're going to go the natural way. I think that's a whole separate issue if
About
we
to
want
say-
to talk about.
I think we could, do a whole bit on abnormal birthing emergencies and,
So
and
just
whatnot.
just because I'm that guy, let me ask you, and you'll probably be able to answer this question for me.
Probably not.
I have 2 patients now in my ambulance. Can mom hold baby during transport?
Yes.
In this case, they have to.
They
Skin to
should.
skin.
Skin to skin.
Right. And there's going to be some people out there that'll butt heads with me on that because the baby should be secured in a car seat and locked down. It's like,
Have you ever
So-
met a mom with a newborn baby?
that won't let her go?
I
Yeah,
mean, take it one step further. You didn't make it to the hospital. You delivered in the squad. What are you going to do?
Right. You're going to have to stop, probably pull over. I mean, again, I hate seeing this, unless it's a small percentile, that this isn't a medical emergency. Let's just calm down.
I think you're.
Dad can go boil water.
I think you're crossing over to 2 thoughts here, and that
Legality of transport and-
well, that secondary, thing is our other edict to transport appropriately and safely in properly sized gear. But you're talking about, in the vast majority of those cases, not a newborn infant. We're talking about a patient, usually a pediatric, that's already gone home and is past this initial
and has an
developmental
appropriately
stage,
sized
right.
car seat. And
That's a different case.
Yeah.
In that case, the answer is, yeah, I understand mom, dad, whomever's going to want to hold the kid. That's a completely different set of circumstances, right? We're talking about this in the field delivery perspective.
But also, another part of resuscitation that we've sort of hit on a little bit but kind of glossed over. So we talked about dry and stem, right? And babies come out wet. A big part of resuscitation is going to be getting your baby warm and keeping your baby warm.
Thermal
absolutely.
regulation.
And the best way to regulate temperature once your baby is dry is going to be skin to skin with the mom.
No, I agree 100% with
Yeah.
that, and a head covering would help too.
Yep.